Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to welcome you all to the first session of the Gulf Intervention Society. My name is Dr. Waqqar Ahmed. I am an interventional cardiologist in Jeddah, Saudiya. And I'm joined here with my co-moderator, Dr. Hadi Habwantash from Jordan. And we would like to go ahead and stay on time. And this is our first session, which is Left Main and Bifurcation PCI. And I will introduce our first speaker, who is Dr. Abdullah AlEnezi from Kuwait. He will be presenting Left Main PCI with the two-stent technique. Dr. Abdullah.
Thank you for the kind introduction. I think we'll go ahead with our case presentation. Left ventricular systolic function. Otherwise, thank you for the kind introduction. Today I'll be presenting a case of left main PCI with the two stents technique. Our case is a 47-year-old gentleman with no significant past medical history. He presented with CCS class 3 angina, and he was investigated with exercise treadmill test, which was strongly positive. He had an echocardiogram which showed normal left ventricular systolic function, otherwise unremarkable test. His blood work were unremarkable. This is his coronary angiography. As you can see, there is a severe eccentric left main stenosis extending to the ostium of the left circumflex and in the LAD. And you can see the circumflex giving a very large OM branch supplying the lateral wall. This is the reminder of the Medina classification. And our case is 111. Which means that the patient has significant stenosis in the left main, in the ostia of the LAD and left circumflex arteries. This is the injection of the right coronary artery, which showed severe proximal lesion, which ultimately was treated with PCI. So with regards to the management of this patient, obviously due to the severe left main stenosis, there is a risk of sudden cardiac death with medical therapy alone, so he definitely needs revascularization. I think the usual question in such cases would be the mode of revascularization, be it PCI versus CABG. Given the complexity of the left main stenosis involving the ostia of both the LAD and the left circumflex, we preferred to refer this patient for surgical revascularization. However, as you all know, in such cases, patient preference plays a very important part of the decision-making, and the patient was adamant that he would not go for surgical revascularization, and we thought that PCI is a reasonable alternative in this case. For one of the most important aspects with left main PCI is procedural planning. This involves decisions with regards to access and choice of guide, whether there is a need for mechanical circulatory support, what is the stenting technique that will be used, and the use of intracoronary imaging is very important in complex PCI, especially left main PCI. So for our case, we went ahead with radial approach using a 6 French guide. Given that the patient was stable and had the normal left ventricular systolic function, we didn't thought that he would require mechanical circulatory support. And with regard to the stenting technique, given that the Medina classification was 111, we decided to go with two-stent technique. And personally, I like to use DK crush because that's the technique I'm most familiar with, and it's the technique that has has the best evidence with regards to left main PCI. And with regards to intracoronary imaging, we did use IVUS in this case, although I had difficulty getting the images, so unfortunately we will not show them in this presentation. So in the next few slides, we will go ahead and discuss the DK crush stenting step by step of our case. So obviously the first step after gaining access and engagement and giving appropriate anticoagulation is to gain access in the LAD and left circumflex with coronary wires. The next step would be to pre-dilate the side branch, which is in this case was the left circumflex artery. So this was dilated with a 3.5/15 scoring balloon because we had difficulty opening it with NC balloon. This was followed by a pre-dilatation of the main branch, which is the LAD, using a 3.5/15 NC balloon, and you can see the vessel is yielding. This was followed by a stenting of the side branch, which is the left circumflex artery, only after barking an NC balloon in the LAD. This is a very crucial step to have your main branch balloon there before you start stenting, because if you stent your side branch before you deliver your main branch balloon, you might have difficulty in delivering the main side branch balloon to do the crushing. After you deploy your side branch stent, there's few considerations before you pull your equipment from the side branch. One is to do an angiogram to make sure you don't have edge dissection. Two is one of the things I really like to do is to pull the stent balloon 2 to 3 millimeters back and inflate at a high pressure to make sure that they have a good position of the stent to the ostium of the side branch, which will help facilitate crossing, recrossing, and reduce the chances of crossing under the stent. And finally, you need to remove all the equipment before crushing the stent with the main branch balloon. So next, we're going to crush the side branch stent after we made sure of all the things that we mentioned and after removing all the equipment. So you can see here now we're going to inflate the balloon in the LAD to crush the left circumflex artery stent. And you can see that the balloon is fully inflated. And it's used, we use the 3.5 NC balloon, which is sized 1:1 to the size of the main side branch. This is just a cartoon showing the importance of crossing in the middle of the stent. Of course, if you cross underneath the stent, between the stent and the side branch wall, you will have great difficulty delivering any equipment. And to that reason, I usually, as I said, before I remove the stent balloon, I pull it back 2 to 3 millimeters and inflate at a high pressure to make sure that the stent is well opposed to the side branch wall. Finally, we recross and do our first kissing balloon angioplasty. And in this case, we used 2 3.5 NC balloons. And as I said, we used 6 French guide. And with the 2 3.5 balloons, it was very difficult to move equipment. So this is one of the considerations when doing left main PCI, is that if you're going to do kissing balloon inflation using big balloons, you might need to use a 6 French guide that has a big lumen, or consider using a 7 French guide. Following the first kissing balloon angioplasty, we go ahead and deploy the main branch stent after removing all the equipment from the side branch, so they are not jailed. As you can see, we are putting a stent in the LAD back to the ostium of the left main. This followed by first pot, and this first pot is very important because now you need to recross into the left circumflex across 2 stent layers, or essentially 3 stent layers, because one of them is crushed, and the main vessel stent as well. And doing the first pot, expand the stent struts and facilitate recrossing. This was followed by recrossing and doing the second kissing balloon angioplasty, as you can see here, again using 3.5/15 NC balloons in the LAD and left circumflex. And again, we had difficulty, so we had to use 2 fresh new balloons to be able to deliver them in the 6 French guide. After doing the second kiss, we do our final pot to optimize the left main stent, and this was done by using a 5/8 NC balloon. All the measurements and the sizing of the balloons and the stents was used based on the IVIS findings. And of course, the procedure was ended by IVIS assessment of the vessel. And this is our final result. And this is just a cartoon showing what kind of minimum achievement criteria for doing left main PCI. Depending on the size of the patient, at least you need to get minimal surface area of the stent of 5 millimeter on the ostium of the left circumflex artery, 6 at the level of the LAD ostium, 7 at the polygonal of confluence, and 8 at the body of the left main artery. So the take-home messages from our case that PCI is a reasonable alternative to CABG in selected cases. However, in such cases, procedural planning is very crucial to optimize the results of your case. I usually avoid performing ad hoc left main PCI because you need to plan for the procedure for all the reasons that we mentioned. Intracoronary imaging is very crucial in any complex PCI, including bifurcation, calcified lesions, CTO, and especially left main PCI. I would recommend that people use the technique they are most familiar with. However, I feel that DK crush has the best evidence left main PCI, and it's the kind of technique that I personally like to use. And I think we got a reasonable result with our case. Thank you for your attention.
Thank you, Dr. AlEnezi. That's an excellent example of DK crush of the left main done beautifully. Do you have any follow-up on this patient? And then we can open the questions to the panel.
We actually have a very short follow-up of this patient, but he did really well. He only stayed in the hospital 24 hours. He was discharged the next day, and he's optimizing medical therapy. We just follow him to make sure that all the other markers, blood pressure, LDL, and are at target. But he's doing well so far, but it's a short follow-up.
Great. Any further questions from the panel? And Hamid?
Very elegant display. Very elegant. Very well done. I think it's beautiful display of the classic DK crush. Good job.
Thank you, dear. If I may make a comment, if you notice that the balloons, the contrast was really prominent in the balloons, and that's maybe one of the things when you do left main PCI, to try to dilute the balloons, because trying to deflate the balloons very quickly, the degree of contrast we had was not ideal. But this is one of the learning points that can make the case better, I guess.
Can I ask you, Abdullah, beautiful case and classic demonstration. I personally like the way you put it. Which are the cases of distal left main, depending on the angle, which you might say, well, maybe that's not a DK crush case?
Well, the cases where you have a close to 90 degrees angle between the LAD and the left circumflex, sometimes you can decide to go with a provisional and maybe do a T stenting or a tap. But to be honest, the vast majority of my left main cases are done with the DK crush, because I feel it has the best evidence out of all the other techniques in the left main. And it's the technique that I'm most familiar with for the left main. And it gives me confidence that I'm covering the side branch. I don't have problems with occluding it with a professional and trying to recross and, being stressed somewhat. So it's my go-to approach or strategy for left main.
What is your advice for people who encounter this as a primary PCI in the middle of the night? Would you advise them to do the classic approach, which you are very experienced with, or do what they are comfortable with usually during those hours? What do you think?
One of the issues of bifurcations, stenting, as Dr. Hamid will talk about, is that there is so many steps in each technique. And I think if you try to master all of them, you will not be very good at any of them. So I think you almost should aim to use the technique you are most familiar with, because there's so many steps. If you miss one of them, it can have can make your case very prolonged, very difficult. So that's why I was highlighting some of the steps that are very crucial in DK crush stenting to help make your case easy and go smooth. So short answer is try to do the technique you are most familiar with.
Just a follow-up questions, if I may, Dr. Waqar. Angle and calcium distribution, is there any features that would make you actually shy away from using the DK crush?
Dr. Waqar, you want to start? Or?
No, I'll let Abdullah answer, and then I will.
To be honest,
move to the next speaker.
I try to make my answer short. With the new technology of shockwave, I'm not sure if all panelists have experience with it, but make the calcium treatment so much easier. I think it's a very effective therapy. So with that technology, and I think it has especially helpful in left main, as opposed to rotablation or something else. So not really. If I can use shockwave, I would. It would not make me change my strategy. I don't know if other people have a different opinion.
We have used shockwave. I've used shockwave. In fact, my first couple of cases, I could not cross the shockwave balloon. So if the shockwave balloon is a bulky balloon, if it doesn't cross, you're back to your rotablator. So, and that's what happened in my first cases of shockwave. We were a little too ambitious, and I was, and I couldn't cross it. So now I know when to use my shockwave. I think we should move to the next case and time to stay on time, and it's a whole day ahead of us. I will ask my co-moderator, Dr. Abu Hantash, to present the next speaker, please.